Afternoon. My name is Delayehu Bekele. I'm an obstetrician and gynecologist working at St. Paul's Hospital, Millennium Medical College. And the topic of my presentation will be a randomized control trial of sequential versus simultaneous use of Foley balloon and oxytocin for induction of labor in nulliparous pregnant women. And I'll be presenting on behalf of the following team. This is the list of the investigators for the study. So to start with a brief introductory remark, induction of labor, as you all know, is an iatrogenic stimulation of the uterine contraction before the onset of spontaneous labor to accomplish vaginal delivery, and it's becoming an increasingly common practice in some centers, contributing for approximately 20% of all births. Cervical status is an important predictor of the likelihood of the duration of labor required before vaginal delivery in induction of labor, and also the success of vaginal delivery. The two major techniques for iatrogenic cervical ripening are the application of cervical ripening agents such as prostaglandins or use of mechanical methods such as insertion of Foley catheters or other cervical dilators like hygroscopic ones like laminaria. Transcervical balloon catheters provide an alternative to prostaglandins for ripening the cervix, and they have been used for this purpose for many decades, and they cause gentle ripening of the cervix without causing uterine overstimulation, unlike the prostaglandins, making them a safe and effective method of ripening the cervix. So normally, after the Foley catheter is inserted for cervical ripening, oxytocin may be started after 12 hours or after the Foley catheter is expelled, or it may be started immediately. Which of the timing is better for the outcome of induction of labor is not well known, and there is positive literature guiding the timing of initiation of oxytocin following insertion of Foley catheter. So in one RCT done by Catherine A. Connolly and her colleagues, the simultaneous use of Foley balloon and oxytocin in nulliparous women led to a decrease in time of induction by close to 3 hours compared to the sequential use. And there was no difference in the rate of cesarean section delivery, estimated blood loss, PPH, coronets, or composite neonatal outcome. In another study, also done by Corina and Scholen and her colleagues, nulliparous women who received concurrent Foley and oxytocin delivered more frequently within 24 hours as compared to those who were started with oxytocin after some hours of insertion of Foley catheter. In this group, the simultaneous group delivered 64% of the simultaneous group delivered within 24 hours as compared to 43% in the sequential group, and there was no also difference in the cesarean section rate and maternal and perinatal outcomes in between the two modalities. A recent meta-analysis of RCTs done to systematically analyze this topic has identified 6 RCTs with a total population of 1,133 participants. And this study has shown that on the nulliparous group, there was a significant relative risk of delivery within 24 hours in the simultaneous group as compared to the sequential one, with no difference in the cesarean section rate or the maternal and perinatal outcomes. So maximizing the likelihood of successful vaginal delivery in a shorter period in a nulliparous woman has a significance, especially in our setup, as decreased hospital stay, utilization of hospital resources such as labor and delivery time, intake of IV fluids, patient overall cost, and improved patient satisfaction. So we have done an RCT to assess whether the induction to delivery time is shorter in the simultaneous group as compared to the sequential one in our setup, as we have a different patient profile and we also use a different oxytocin protocol, doing similar type of study rather than just adopting the findings from the few artists in the West is recommended. So we did the study with an objective of determining whether the induction of labor with simultaneous use of Foley balloon and oxytocin decrease the time to delivery as compared to sequential use, and also to determine if there is a difference in the cesarean section rate and the composite neonatal outcome and maternal complications such as infection, blood loss within the two groups. So we did a two-arm randomized control trial. The arm one is a simultaneous use of the Foley catheter and oxytocin, while the arm two is a sequential use of catheter followed by oxytocin. So our primary outcome was induction to delivery time, and the secondary outcomes include cesarean section rate and maternal complications, including PPH, choral amnitis, and tetanic contraction, and composite neonatal outcome. The study was done at St. Paul's Hospital, which is a tertiary referral hospital in Addis Ababa, and the source population were all mothers coming to the hospital for antenatal care, labor and delivery services, and specifically the included participants or the inclusion criteria were Nulliparous women with 28 of gestational 28 of weeks of gestational age and above, with an alive non-abnormal singleton fetus in vertex presentation and with an initial cervical dilatation of less than 3 centimeters, were admitted for induction of labor for induction as determined by their primary provider, and cervical ripening with Foley balloon was decided. Patient and those who were excluded were patients with prior uterine surgery, unexplained vaginal bleeding, if they have any latex allergy or any contraindication to vaginal delivery. A sample size of 140, 70 from each arm was calculated, assuming a confidence interval of 95% and a power of 80%, and with a 1-to-1 ratio to the two groups, and to detect at least a 0.5 hour mean difference in the induction to delivery time. So eligible women were identified by the labor and delivery staff, residents and at OPD and maternity ward and labor ward. And patients were then approached by study personnel and informed about the research and counseled on the risks and benefits of participating in the study. They were informed that their participation will be voluntary based, and choosing not to participate in the study will not affect their care. Randomization scheme was prepared prior to start of the study. A permitted block of differing size between 6 to 10 were used, which was prepared using a computer-based random number generator, and cards allocating the patient to either simultaneous or a sequential group were placed in a sealed opaque numbered envelopes, and after the signing informed consent, participants were given the next envelope from the consecutive numbered envelopes. And for those patients who were in the simultaneous arm, oxytocin was started within 1 hour of the insertion of the Foley balloon catheter. And for the sequential group, oxytocin was started within 1 hour of spontaneous expulsion of the Foley balloon, or after 12 hours of insertion, whichever comes first. And for all patients, the remainder of the patient care and the labor follow-up was managed according to the standard protocol of the hospital. Data was collected through abstraction and interview by trained midwife nurses, and a structured case reporting form, CRF, was completed starting from the assignment into one of the groups during labor and discharge. And data was entered into AP Data Manager as by devil data entry. And ethical clearance was obtained from the review of St. Paul's Hospital Millennium Medical College and also from the National Ethics Review Committee. And the trial was registered in the Pan-African Clinical Trial Registry with the number shown here. Analysis was made with an intention to treat analysis basis using Stata version 50. And And when we come to the results, a total of 153 women were considered eligible for the study, and they were approached, and 140 women were recruited, 70 in each group. 13 patients were excluded because 8 has declined, 3 has history of APH on deeper digging of their history, and 2 has cervical dilatation greater than 3 centimeters on further examination. So when you see the baseline characteristics, there is no difference in between the two groups except mean gestational age, which was lower by 0.85 weeks in the simultaneous group. Otherwise, all the other parameters, including the maternal age, the initial Bishop score, body mass index, and the indication for induction of labor, were similar in the two groups. So when you see the induction to delivery time, there was no difference in the interval between the initiation of oxytocin to delivery time between the two groups. And the median of induction to delivery time being 6.9 in the sequential group and 8.1 in the simultaneous group. And when we specifically see for those who have delivered vaginally, it was 6.9 in the sequential group and 7.0 the simultaneous group. So this is different from the findings in the Western countries, which has shown that the induction to delivery time was shorter in the simultaneous group as compared to the sequential one. But of course, if you consider the Foley catheter insertion to delivery time, it was much shorter in the simultaneous group with a median time of 8.6 hours compared to 16.9 hours in the sequential group. It was almost twice out of the simultaneous group. The Ceserean section rate was also not significant between the two groups, being 40% and 48% in the sequential and simultaneous group. And multivariate binary logistic regression to assess factors affecting the Ceserean section rate and the maternal Ceserean section rate has shown no difference when you see it by maternal age, BMI, gestational age, birth weight as a predictor variable. And when you see the maternal and neonatal outcome, there was no difference in the rate of uterine atony, chorioamnionitis, the birth weight, and the composite neonatal outcome in between the two groups. But the tachysystole or tetanic contraction was more common in the sequential group as compared to the simultaneous one. So we have found that the induction to delivery time, which is defined as the time elapsed between the initiation of the first dose of oxytocin and delivery of the baby, was not different in between the two groups. And this is different from the studies done in the US, and which has found simultaneous group delivered in a shorter period than the sequential group. And this might be due to the lower dose of oxytocin that we use in our setup and a prolonged cervical ripening and in placement of the Foley catheter might be needed to cause a shorter induction delivery to show the difference in the induction to delivery time in our setup because of the lower dose of oxytocin. And we have analyzed also the Foley catheter insertion to delivery time, and it was significantly shorter in the group by simultaneous group by more than 8 hours. And this is worth noting in the facility like ours, where there is critical labor ward shortage, and simultaneous use of Foley catheter may reduce the bed occupancy and the healthcare providers' time in such busy labor and labor ward settings. So this, although this was not our primary outcome, but it is worth noting. And the use of both regimens did not result in statistically difference rate in Cesarean section, and most importantly, there is no difference in CS rate for failed induction. So the CS rate is high in both groups, and the overall Cesarean section rate was 62.84. It's much higher than the rate from the other similar studies in the US, which have shown a Cesarean section rate of 42.1 1.7, and this might be due to the difference in the oxytocin regimen again, and the absence of backup fetal monitoring guidance, which could help to reduce the cesarean section rate, and the fact that the setup for the study was done in a tertiary setting where high-risk mothers are managed may be also one contributor to the higher cesarean section rate as compared to the other studies. And the most common indication for cesarean section rate was non-reassuring fetal rate, and this is different from the previous RCTs where failed induction of labor was the leading indication for cesarean section rate. And in our study, there's no difference in the contribution of non-reassuring fetal rate for cesarean section rate in between the two groups. While in the previous RCT, there was a difference between the two arms, and the simultaneous group had higher rate of cesarean section rate than for non-reassuring fetal rate. There was no case of postpartum hemorrhage, and the rate of coronets and uterine atony was very few to make a reasonable assessment of difference in between the two groups. And the rate of tachycystole was more common in the sequential group, and this is contrary to the previous studies, which have shown no difference in between the two groups. And the prolonged time the Foley catheter stayed in situ might result in a release of endogenous prostaglandins, increasing the chance of theta contraction, and this might explain the higher tetanic or hyperstimulation in the sequential group. And the composite neonatal score was comparable in between the two groups, and this is in concordance with the previous RCTs. So the study has some limitation. It was not blinded because of the nature of the intervention, and the maternal and newborn contractions were complications were few in number in both arms, making analysis of the secondary outcomes weak. So in conclusion, in contrary to the previous RCTs, which have shown the simultaneous initiation of oxytocin to have to reduce the induction to delivery time, our study hasn't shown that. And as there is no difference in the cesarean section rate, maternal and perinatal complications, patients should be counseled, and based on other clinical characteristics, also individualized choice of decision can be made whether to start with simultaneous or sequential induction of labor. And as the first experience of in-house investigator-initiated RCT in our setup, lots of lessons for improvement has been learned from this RCT. Thank you.